一起在网络平台关于等离子的话题进行互动。
We welcome all of you from different countries to join us in this discussion with the technology of plasma surgical system.
非常感谢大家，谢谢。
Thank you very much. Thank you.
可以了哈。So now now with our warmest applause, let's welcome our first guest, Professor Glen Burgess from Monash Specialist Centre, Australia. Professor Glen Burgess became fellow of the Royal Australian College of Surgeons in otolaryngology, head and neck surgery since 2000. He started teaching in otolaryngology, head and neck surgery since 2002 and has very rich experience in snoring and sleep cases. Today, he would share his rich experience with us on the topic of tongue-based reduction with plasma technology. Let's welcome Professor Glen Burgess. Welcome.
Thank you very much. Thank you for the very kind invitation. It's been my pleasure to be invited here, and I think I've been one of probably the earliest users of Plasma One technology in Australia since about 2002, when I returned from my fellowship in the UK. And whilst I was in the UK, we did find ourselves in places that are very relevant to snoring and sleep apnea surgeons, including places like Great Snoring, which is in Norfolk, and I think very pertinent to what we're talking about tonight, because I think most of the time if we find that the patient's not snoring, they don't have sleep apnea, but it's a real place. So I thought I'd talk about the use of radiofrequency, particularly of the tongue, to reduce that in the appropriate patients. So have I got control of the slides? Can we move on? Slide doesn't seem to be moving. So we're talking about the contemporary management of sleep apnea and snoring. I've developed an interest in the surgical treatment of these two areas over the last 10 to 15 years as a sort of natural development of the use of Plasma One technologies, which we're all aware of. Next slide, please. We're all familiar with the bed partner coming to us, often dragging the husband or the wife with a very unhappy face and a very disturbed sleep. And often we'll find that the bed partner who's been complained about also, if we ask a little bit about them, is also having quite a poor sleep as well. So this type of slide is a frequent scenario in our rooms when we're talking to the patients. We know that the treatment of, next slide please, the quality of life is important because of the risk of tiredness and poor performance of our everyday jobs. And we're well aware of cardiovascular risk factors such as myocardial infarction and cardiovascular accidents, as well as the reducing productivity and the risks of accidents with the motor vehicles and machines at work. Most of our patients, sadly, are mostly given uncomfortable, difficult to use machines like this CPAP mask, and often they come looking for other treatments to try to get some help. So next slide, please. Next again. So how do we diagnose our sleep apnea? And I'm sure this is familiar with all, so we'll go through that quickly, but you tend to hear nearly always that there's snoring and often there's daytime somnolence. So we ask the history of those two events, and it's good to have the bed partner with us or someone who's witnessed the patient's sleep. And of course, we go to do a sleep study next, either a formal polysomnogram or, as I've tended to use in my rooms the last few years, a watch pat device, which I find very easily used by the patients, and we get good results. Next slide, please. So what are we talking about with snoring and sleep apnea? Well, we're talking about a narrowing of the upper airway, which causes noise, and sometimes if the patient is narrowed too much with high inspiratory pressures, we see collapse with sleep apnea. Next slide, thanks. So we're talking about the sleep apnea occurring at the whole of the upper airway from all of these points which are relevant, either from the nose with septal deformities, turbinates, polyps. As we come to the palate, we might find adenoids, might find a long floppy palate, we might find palatine tonsils, macroglossia, lingual tonsils. Epiglottis is not uncommon to find involved with this. And if you look at humans, yes, next slide please, where we have the obstruction, particularly down here, humans have a differentiation from our hominid cousins where we have our epiglottis and our larynx descended down into our throat, which allows us to phonate, but also opens up the opportunity for us to get airway obstruction, which of course the apes don't have because the epiglottis is high up and they don't tend to collapse. But of course they don't talk either. So next slide, please. So what are we trying to aim for? We always should be aiming for something which we want to achieve. We want a good night's sleep for the patient. We want a quiet sleep for them and their bed partner. We want to avoid daytime tiredness and cut out risk factors, and we want to improve the quality of life. The next slide, please. So, of course, like everything in medicine, we have a diagnosis, and that includes an assessment, and management, and treatment. So the diagnosis is, and next slide, please, made on examination, and we look through the nose, the mouth, and the pharynx. Next slide, please. We look in the nose for septal irregularities and deviations. We look for allergic changes in the nose. We see many patients from a Chinese background in Australia, particularly in the southeast, with very large problematic turbinates because of the allergic changes we see in some racial characteristics in the nose. We may see nasal polyps, and we may even see adenoids, particularly in the child. Next slide, thank you. When we look in the mouth, the obvious thing we look for is tonsil size. Even our general practice colleagues will look at that. But we also need to look at tongue size, the palatal anatomy, where it's narrow or wide or very corrugated, which you'll often see in a snoring patient. And we'll do a modified Mallampati index, which many of you would have heard about, and we come up with an approximation of a Friedman classification very commonly too. Next slide, thank you. So the Friedman and modified Mallampati index talks a lot about the tonsil size, and we tend to get a tongue size position where we go from 1, where we see the whole of the uvula and the soft palate, to 2, where we see all but the end of it, and in 3, where we see about half of the soft palate and the uvula, and 4, with a very large tongue, we only see possibly the hard palate. The next slide, please. And then we look at the tonsil grade, where 0, where there is no discernible tonsils, 1, where they may come to the pillars, 2, beyond the pillars, 3, beyond the pillars and nearly in the midline, and 4, where they are meeting in the midline, which is something we'll often see in children, but occasionally in adults as well. The next slide, thank you. So then we put those two classifications together, and Friedman produced this to look at the effectiveness and the likely effectiveness of his tonsillectomy and UPPP in helping sleep apnea. And he worked out that if the tongue size wasn't too bad, a 1 or a 2, and the pharyngeal or palatine tonsil size was great, he would call that stage 1 as long as their BMI was less than 40. And then we got to 2, where the tongue is getting a little bigger, and we get the tonsil size getting a little smaller, and we get less likelihood of improvement with a tonsillectomy UPPP. We get stage 3, where the tonsils are getting smaller and the tongue is getting bigger, and stage 4, where we're getting any size of the palate but small tonsils. And he graded that as to the likelihood of that would work. The next slide, please. And then we came up with the likelihood of success with a UPPP or tonsillectomy, which was very high in stage 1, middling in stage 2, and not very likely in stage 3. And of course, that was dealing with the tonsils and palate. But of course, we're talking about the tongue today, and tongue size reduction is where we start to think about this in stage 3 conditions. So next slide, please. So we look at the palate and the tongue. We look at for lingual tonsils, which is very important. We look for tongue-based anatomy. We look for pharyngeal cysts, occasionally tumours. And I only took a very big tumour off someone last week that had an SCC that was beginning to snore. And we look at functional collapse. Is it weight related? Are they carrying a lot of weight in the neck? And is it beginning to impede, particularly in lateral collapse? So next slide, please. Of course, we use a nasendoscope through the nose and down to have a look at the palate from above and the palate and the tongue together, and beyond that in the epiglottis. Next slide, please. So we use the nasendoscope. We may get them to snore, and in the old Muller maneuver, I tend to use that a lot less these days. I tend to do a version of Tucker Woodson's hypotonic maneuver, where we get the patients to exhale as much as they can and try to relax the upper airway. We really start to see the pattern of collapse. Of course, it's not perfect. It's not the same as them being asleep, but it's also probably just about as close, I believe, as what we might get with a general anaesthetic and assessment there, which of course has its own problems. And we use that to assess the site of collapse. And I tend to find those combinations of examinations very closely relate to what we see when we look at their sleep study. So next slide, please. So of course, the management, we have to offer the patients every aspect that we can consider, and the standard of care with our respiratory colleagues has always been a CPAP mask, or sometimes a mandibular advancement splint. They'll often offer lifestyle things, and weight loss is often a big part of that. Sometimes there's changes in pillow and devices to try to keep them off their back. And our respiratory colleagues often reluctantly come to us for surgical help, but a lot of the patients will seek us out themselves. So next slide, please. So our surgical treatment has to be specific to the site. It has to be graduated. We don't offer too much too early if that's not necessary. We have to be able to assess it. We can be curative or complementary, and if a patient has multiple causes for their sleep apnea, sometimes we'll just offer them an improvement in their sleep with surgery, possibly so they can have a CPAP machine, or possibly a CPAP machine at a lower pressure that may be tolerated. And often we'll see that in very obese patients where we know we can't cure them, but their CPAP pressures are so high that they can't use it. We may be able to improve their airway without curing them, but at least allow them to get some treatment. And even if we can't cure them, often they'll get a significant improvement in their sleep anyway on their symptoms and their quality of life. So next slide, please. So the CPAP, our respiratory colleagues talk about the gold standard, but it's effective in less than 60% of patients. We see that more and more. Either it's not tolerated, it's uncomfortable, they find it intolerable, or claustrophobia may be a big issue. Next slide, please. So we talk about the sleep apnea management in whole populations, and our respiratory colleagues believe it's 100% effective, but it's tolerated by less than probably 40% of patients who use it less than 40% of time. And they may say, well, your surgery is less effective, but once we've done it, it's being used 100% of the time. So we have this conundrum where we have a very effective treatment in CPAP, but it's not very well used, versus sometimes the surgery may not be 100% effective, but it'll be used all the time. The next slide, please. So our aim is to cure or improve the sleep apnea, and we know that it's very effective with management of sleep apnea, and it's a very good chance of cure in mild and moderate, and it's a good treatment in moderating severe sleep apnea. So next slide, please. So the quality of life measurements by my old colleague, the late Sam Robinson, back in 2009 showed that upper airway reconstructive surgery, according to his techniques, which are followed by many of us, showed a significant improvement in the long-term quality of life for patients with sleep apnea, particularly when they were compared to CPAP machines, and that had equivalent quality of life outcomes, showing good equivalence in what we're aiming for. Next slide, thank you. So the three major patterns of airway collapse: side to side, which may be lateral from the tonsils or weight in the neck, antero-posterior, or a combination of the above two. So next slide, please. So the treatment, next slide, thank you. Next slide, thank you. So we look at the conditions where we might get antero-posterior collapse, and a lot of it is tongue collapse, but there may also be lingual tonsils, there may be vallecular cysts, there may be an epiglottis that's flopping back, and we see that more and more, or there may be a combination of any number of those four above. So next slide, thank you. So the new techniques where we bring in plasma one technology, we see improved operations that are available either with tonsillectomy or intracapsular tonsillectomy that some of my other colleagues will talk about on the panel tonight, where we reduce the size of the tonsils, or where we shrink away the lingual tonsils, or whether we do tongue-based reduction, which is my topic tonight. The next slide, thank you. So this is the bonds console and the Bond's wand, where we use currently to shrink the tonsils down, and we see the active electrode at the bottom of the wand which connects in, and that is where we get the tongue, the whole of tongue channeling done through this area when we put it into the body of the tongue. So next slide, thank you. There's a new slide coming out, and if you hit the video, we'll see that this is an improved version of that, where we get more saline coming over the tip, and where you can withdraw the sheath slightly, as the demonstrator will show you. And I find this very effective, particularly in the early stages of the tongue channeling, where it really delivers the saline onto the spot. And we're familiar with plasma, where it gets that orange hue, which is the sodium, particularly in the plasma being generated. And if you're unsure, and I always check this first before I put it in the patient, I always put it in some saline, because sometimes the theatre technicians can connect these things wrongly, even despite the best of efforts. And sometimes we have new technologists, so we need to make sure that it's on and working before we go and start putting it into the patient's bodies. Next slide, thank you. And next again. You'll see that. So we're going to have an effective subtotal reduction of the soft tissue, palatine, lingual, tonsils, the adenoids, sometimes tumours, and the tongue, which is what we're talking about tonight. So next slide, thank you. So we're aiming for an improvement in the airway for obstructive sleep apnea, hypopnea syndrome, where the retrolingual collapse is a significant factor rather. We've had a significant number of patients done over the last 10 or 15 years, but it's not something that's been routinely offered in many centres. So, next slide, thank you. So I first learned about it from Professor Zhang from Dalian many years ago, when I attended one of his lecture series there, and he'd done a review of over 2,000 cases and shown it to be very effective. Next slide, thank you. He had found in mainland China 3.6% of adult Chinese men particularly were having symptoms of obstructive sleep apnea. He found that there was generally a multifactorial cause for it, but over 90% of patients did have some hypertrophy of their tongue or macroglossia. And next slide, thank you. So he introduced the concept of plasma tongue channeling, where we are aiming for a surgical reduction in the macroglossia for sleep apnea, where we see tongue-based collapse as a significant factor. And this is an alternative to CPAP for those Friedman and Mallampati classifications, which are not likely to improve on the basis of their anatomy. And after we've done an endoscopy and seen tongue-based collapse, and we've seen particularly supine-related collapse in the polysomnogram or their watchpat. So it's an alternative for CPAP where it's not tolerated or it's not suitable. Next slide, thank you. So our experience at Monash, my personal experience, has been over 3,200 cases to date, and we found it highly efficacious and very effective in reducing the tongue size. We've had very few complications over the last 10 to 15 years. It's generally been very well tolerated. And what we've found, in addition to Dr. Zhang's work, where we're dealing with more of an Anglo-Saxon population, we'll often find the tongue is longer and sometimes bigger because of different anatomy between the races. And I'll find that I'm often putting quite a lot more channels than what Professor Zhang was first speaking about, where he would generally do 5 in the midline. Often I'm doing 7 or sometimes 8, and then 5 to 6 in the lateral side, and possibly 2 or 3 in the paramedian position as well. So next slide, thank you. Of course, we're looking at the oral appliance as an alternative, and there are many things that are being put out there, and all of your patients will come to you and talk to you about whether they've tried a splint either across the counter or across the internet. Sometimes they've been made well by a dentist, and sometimes they haven't. And of course, the alternative is a CPAP machine where we're blowing air in under pressure. So next slide, thank you. There's almost no end to that. This is the ideal appearance of someone with a CPAP machine. Next slide, please. Unfortunately, the second slide is much more likely to be the case, where we have an obese man with, a very large full face mask that are very difficult to tolerate. Of course, this wouldn't be an ideal surgical candidate either, but more likely to be someone who we might be offering complementary care to, surgery plus sleep apnea and weight loss regimes with the help of our dietitian and possibly bariatric surgeons. So next slide, thank you. There's a lot of other things out there too, which is quite surprising to me in the research for this talk tonight. Such things as tongue retaining devices, kind of like an inverted baby's dummy, where the patients stick their tongue in through suction. It pulls them out, but these gives a very uncomfortable tongue with often numbness and discomfort in the morning. Next slide, thank you. This is how they're supposed to work, and I had a patient bring this into me, and he cursed the thing. He didn't like it at all, but he'd been given it, found it online. It found it was helpful, but he did wake up with very sore, uncomfortable and numb tongue in the morning. Next slide, thank you. This is a picture of someone lying there in bed with effectively a tongue retaining device in, and also some nasal strips as well. Obviously someone who didn't want to consider surgery. So next slide, please. So we're looking at how we're trying to optimize the airway to reduce that retrolingual area of collapse here behind the tongue at the lingual area. So we can open this up and there's no collapse. And our tongue channeling will not only shrink the size of the tongue, but it'll also, in my experience, make the tongue stiffer, so it's less likely to fall back. Because of the channeling creates some scar tissue with the body of the tongue, and it tends to give it much more stiffness in my experience. So next slide, please. One of my patients brought this into me one day. This is from my desk at work. This is something he'd bought over the internet, and this is something he put into his mouth, hooked over his bottom teeth, and hung over the back of his tongue to pull it forward. He told me this was in desperation. It was extremely uncomfortable. He did tend to choke for a lot of the night, but it did help. But then he started to think about there must be another option and sought out a surgeon. So it's another option that I'd only seen once before. Next slide, thank you. So after our scope, and we've assessed the tongue base is ready to go for the patient, and that's where an issue, we'll go on to the next slide. This is the type of patient we tend to see, and this is from Dr. Zhang's group, obviously a Chinese man with a significant macroglossia, not only length but width is an issue here. Next slide, thank you. So traditionally, movement of the tongue with surgery was related to around generic glosses advancement, hyoid suspensions. We're trying to pull the base of the tongue forward. These are quite problematic, or they're still performed in some areas. I've not had a good experience with it, and it's not part of my practice. Then early on, there was channeling done just at the base of the tongue through some techniques, and these also had problems. They were less efficacious. And now we've moved on to the slide on the right, which is showing channeling of the whole tongue, which we find much more effective. The next slide, thank you. Of course, we want to do it safely, and we are aware as head and neck ENT surgeons that there are some significant vessels and nerves in the tongue, and of course we wish to miss them and not damage them. But I must say, by following the good anatomy performed by Professor Zhang, I've never had an issue with a major lingual artery or hypoglossal nerve damage, but we do need to keep very closely to the anatomy that we're aware of. And as we go through the slide, we can see from the top left side, as we're behind the foramen cecum, the lingual artery is quite widely distanced from the midline, 13 millimeters on average, plus or minus 0.8. And as we come closer to the midline of the bottom, as we get only 2.5 centimeters from the apex of the tongue, the lingual arteries come quite close to the tip there, only 3.5 millimeters on average. The distance from the surface comes a bit closer, from 23 to 19. And the hypoglossal nerve behaves exactly like the lingual artery, a little bit closer on the inside as it goes from lateral, from posterior to anterior, and also slightly higher from deep to superficial, but not too much. The main issue is that it comes in from lateral to medial as we get closer to the apex of the tongue. The next slide, please. This is Professor Zhang's work, which was very widely found to be helpful, looking at the artery and the nerve as they come closer, and he got a ratio there of how we needed to avoid it. So we tend to stop putting the channels into the tongue, particularly in the midline, as we get closer to 2.5 centimeters from the front. And as you do it with the channeling, you do find as you get closer to the tip, you do get more fasciculations, as you tend to get more neural stimulus as you get close to the tip, and it gives you a slight warning there. Next slide, thank you. So this is a picture from one of my patients showing just as we're about to put the probe in. This is the typical position we do it in. I tend to do it with the patient slightly elevated on the bed in the similar position to where we may do nasal surgery. I tend to use a lip guard and then a bite block, and then gently hold the tip of the tongue in some gauze as we identify the anatomy. I try very hard to have the tongue pulled forward in the midline so you can observe the anatomy. You're not pulling it to one side and twisting it. Then you observe the foramen cecum and you come a centimetre in front of that, and with some saline hitting the tip there, then you can just proceed that into the tongue base as you go down approximately 15 millimetres. Next slide, please. This is the anatomy we're thinking about, and I won't bore you with the details there, but just reminding you, which I think is important to do that. And I always encourage people to do some tongue dissections before they start to do any tongue channeling, because you want to have an idea and convince yourself that the anatomy is where we tell you it is before you embark on this, because of course with you in theatre, the importance of you knowing the anatomy is very important. So next slide, please. This is the start here. I think this is a video starting, if we can hit that, or it just may be a picture there in the midline as we're about to start. And we go to the next slide, please. I think we'll get to a video in a moment. So when we look at does it work a lot or not, we looked at an Australian study where we looked at the modified UPP and expansion sphincterplasty with tongue channeling, and when we combined the two of things together, we found that it was highly efficacious, and it was a very good intervention for sleep apnea with minimal problems for the patient. And it was something that, whilst when we found it was effective, we should consider it for patients who are unable to use a CPAP machine or other devices, or unwilling to try it. So we found it very effective in an Australian trial. Next slide, please. So we find the pattern of airway collapse, lateral and front to back with obesity or tonsils, and anteroposterior with the tongue hypertrophy or a smaller jaw, and sometimes with supraglottic lingual tonsils, which we need to deal with. Next slide, please. This, of course, is a large vallecular cyst. This is the lintome and a vallecular cyst causing sleep apnea, pushing the epiglottis down here, and the intubation tube there. That was a cause of sleep apnea, which you can't forget. And by this stage, I've done a plasma wand reduction of the lingual tonsils. You'll see the greyish white tissue being removed there as we're about to move on and remove this large vallecular cyst. Next slide, please. So lateral collapse is palatine tonsils, weight and obesity, or a combination. That's not what we're talking about today. We're going to move on to the tongue. So next slide, thank you. This is a diagram of, I think, the first 40 odd patients who we did, which showed a very good reduction in the apnea-hypopnea index across the slide here, from some very high levels and some less high, but generally we had an effective treatment for nearly all of them. Sometimes we had outstanding successes, and sometimes the successes were less, which led us to a study on loop gain and other reactivity changes that the patient may have that doesn't always explain that may go some way to explain why they have some differential results from their sleep according to other factors, not just the anatomy and tongue size reduction. So next slide, thank you. This is the video of the tongue coblation. This is the palate above us and the tongue there. And if you can start the video there, I'm already starting a centimetre in front of the foramen cecum here. And we give it 15 seconds by the clock with one of the nurses counting it down. I get them to count every 5 seconds and then count me down from 10 to 15. I get them to count out loud because they can be distracted and they can lose their way, and we do need to watch them. When we go into the tongue, you'll see some saline over the tip there hitting the tongue, and I find that's very effective in helping you go through that hard outer keratinized layer of the tongue, so you can go through quite easily, and it just slips in, just a quick touch on the pedal as the wand goes in, and then you give it 15 seconds at the usual rate, and you can see quite a wet end there, which helps us go in. We give it 15 seconds per shot, and then we move 1 centimetre forward on each side until we get 2.5 centimetres from the tip. So next slide, please. This is the lateral channels. This is the side of the tongue. It's a little bit hard to see sometimes, but because it is quite difficult to get the video in to show you. But we start on the dentate line on the tongue, which is the change between the keratinized epithelium and the more softer mucosa on the lateral side of the tongue. If you get in right in the correct plane from top to bottom, you'll find that it's almost bloodless. And if you're slightly out of it, you will hit some more vessels and you will get some bleeding. It just, in my experience, tends to mean that you need to move a little bit more superiorly there as you come along on that dentate line there, 1 centimetre, starting as far back as you can reach to approximately 2.5 centimetres from the tip there, and you give it 15 seconds a shot as per normal. If you get any bleeding, it's usually from the surface, and you can give a little bit of a hit for a few seconds using the bipolar effort, or sometimes just simple pressure can do it. And rarely I can put a over and over a stitch through it. That's rare, but I've had to do that a few times. It's better than getting a hematoma of the tongue. And this just shows us going along the lateral wall, where we'll generally do between 5 and 7 on the lateral aspect of the tongue, which gives a good result and shrinks it further. So I generally do the midline, one side then the other, then assess everything for hemostasis with pressure or bipolar, and sometimes a stitch, but the stitch is tending to be quite rare to be used. The next slide, please. So some results, and everyone likes to show the good results, but this is a patient whose weight was steady and had lingual tonsillectomy with tongue channeling and a palatal advancement up in July 2014. And we saw with the weight unchanged, we saw their apnea hypopnea index drop from 35, which is severe, down to 12, which is mild. And we saw their minimum saturations improve from 70 to 75%, with a dramatic improvement in the quality of this patient's sleep. And they complained of no tiredness whatsoever, and the snoring was brought under good control, and their partner was happy. Next slide, please. This is another gentleman we did back in 2014. Again, quite a large man, 105, 104 kilograms, very bad sleep apnea, an apnea hypopnea index of 107.4, so mega severe sleep apnea, who went on and had tongue channeling, tonsillectomy and a platyplasty, and then we dropped his apnea hypopnea index from very, very severe to 15, and we saw the other aspects, the obstructive apneas dropped from 89 to 2, in REM sleep, in non-REM sleep, they dropped to that. In REM sleep, they dropped to nothing. Hypoapnea has dropped as well. And then his general improvement changed dramatically, and he was an absolute poster boy for our surgical success, and couldn't have been happy with the result. We saw that as well with his tiredness score going from 20, which is very severe, to near normal. So next slide, please. This is a kind of MRI we like to see. We've tried to do a study looking at the MRI with tongue base, comparing that before and afterwards, but it's been quite problematic, and we're still in the middle of doing it because it's not been an easy thing to get it done exactly and to make sure you're always in the same plane. But this is from Professor Zhang's series, which shows a lot of tongue base collapse here, hard up against the palate, but not much space here. The patient's obviously had a palatoplasty, and the tongue is substantially shrunk down here. And his surgery is certainly shown at 4 months post-operatively the retrolingual airway is opened up very well. Next slide, please. So the average of his 500 cases 12 months after tongue channeling was a substantial improvement in the saturations through the evening from an average of 89 to 94, a substantial reduction in the apnea hypopnea index from an average of 26 to 7, and the Epworth score improving from 9 down to 4. There were a few pains, like our patients have some mild pain between day 0 and 5, but generally the tongue channeling is very well tolerated with minimal pain. Sometimes we see slight swelling, as Dr. Zhang did, particularly if you do many channels and we're getting up into the higher numbers, some soft tissue swelling in the floor of mouth can be seen. But he didn't have any problems with perioperative hematoma, abscess, shortness of breath, or dysphagia. And I've only had one serious patient who had some swelling there, which needed to hospitalisation for a couple of days, and then just treatment with steroids and antibiotics resolved her problem. So, and that was on a reviewed patient as well. So next slide, please. Try that next slide. Here we go. The mean change in Professor Zhang's tongue volume in the sagittal area was 103 to 98. In the coronal volume was 108 to 101. And these were significant. And then the retrolingual airway opened up approximately 3 to 4 millimeters. But what we've seen is that it doesn't seem to be related to the patient's symptoms. Sometimes we can have a dramatic improvement with less obvious changes, and sometimes we don't see as much as we like, but the patients still feel better. And there's certainly more going on than just the tongue size. I think it relates to the stiffness of the tongue, and the tongue channeling certainly helps that. There are a number of other factors involved, not necessarily related to the size of the airway. Next slide, thank you. So the complications, occasionally we get bleeding if you're out of the plane. That can generally be well treated with a bipolar touch with the wand. Occasionally need to suture it. I give all patients some dexamethasone intraoperatively and that night, and sometimes the next morning if they've had a lot of channels, particularly the ones who are getting 7, 8 or 9 in the midline channels. Ice to suck, pain's usually minimal. Usually the ice helps that, and sometimes just some simple paracetamol is all we require. But often, if they've got more extensive surgery also done at the same time, tonsils, palate, etc., they'll be on some stronger painkillers for that. Next slide, thank you. So the taste, we've not seen any change in that of any significance whatsoever. For the airway, to reduce the tongue size swelling that can occur, it's important to minimize the saline infiltration if the wand has the saline. We give them all dexamethasone, and if we're worried about their airway, either with swelling or it's particularly small, then I have a low threshold to put a nasopharyngeal airway in and secure it, but I don't have to do that very often, but I'm quite happy to do that if I need to. Next slide, thank you. This is a couple of patients from early on where we did have some slight bruising on the side of the tongue, but this rapidly resolves and we've never had any significant problem more than 5 or 6 days later. Next slide, thank you. It's also a good treatment for our Down syndrome patients, the trisomy 21, where they particularly have a very large tongue. And if I thought that my average Chinese patient might have 5 midline channels and possibly an Anglo-Saxon could have between 5 and 8. Sometimes with the Down syndrome patients, we're finding ourselves doing 10 or 11 midline channels with a similar number of lateral channels. And the Beckwith-Miedemann children, we've done a few of those as well. But we've had dramatic improvement with the children with their degree of dysphagia, their degree of ability to speak and sound much more normal, and to reduce the drooling and the tongue too large for their mouth has been very significant, particularly for the parents when they don't like the child to drool a lot. That has improved the quality of life dramatically for some of these patients. And if they're patients with they're biting the tongue and we're worried about premalignant leukoplakia, we've had a few of those. We've also done some channeling to shrink the tongue down for them, and that's been very effective. So next patient, next slide, please. So overall, we want to think about our sleep apnea and snoring patients. We want to investigate them. We want to look at their level of obstruction where it may be, and we want to offer a range of individualized treatments according to their own anatomy and needs. And that can be medical, surgical, or device, or a combination of any 3 of those things. Next slide, please. Our aim, of course, is to get a happy night's sleep for both partners, whatever they may be, so that the patient is happy, their partner is happy, and as a result, they're happy. And we try to get pictures like this, obviously stylized, but that's what they come back to if you've got a good sleep outcome for them. Next slide, please. We're trying to avoid the angry partner who is ready to kill the snoring patient, either with a hammer or other devices. The noise can be extreme and they can be driven to quite extreme measures, hopefully not the mallet to the head, but they can come and see us and we can do whatever we can to try to fix the problem as we aim for the next slide, please, which is a happy night's sleep, whatever their age, and a good night's sleep and a happy partner. The next slide, please. So thank you for your attention from Melbourne, Australia, where we're enduring the COVID issues, but try to avoid the second round at the moment. So thank you very much for your kind invitation to talk about our experience there, and I hope it's been of some assistance. Thank you.